In this module, we are going to discuss the coronary anomalies of clinical significance in pediatric cardiology. We are primarily going to concentrate on Al-Kappa. Al-Kappa refers to anomalous left coronary artery origin from pulmonary artery. Towards the end of this module, we also will be briefly touching about anomalous right coronary artery from the pulmonary artery. This is a cartoon example of Al-Kappa. You see that the left coronary artery is arising from one of the sinuses of the main pulmonary artery. The right coronary artery continues to retain its origin from the aortic root. And since right coronary supplies the entire myocardium in this situation, it's hugely dilated. When we talk about the pathophysiology of Al-Kappa, in fetal life, the aortic pressure and the pulmonary artery pressures are similar. There is a very similar coronary perfusion pressure in the left and the right coronary artery systems. What we describe as the coronary perfusion pressure is the mean pressure in the root of the coronary artery minus the mean pressure in the coronary sinus. In other words, in the situation of Al-Kappa, the coronary perfusion pressure in the RCA will be the aortic mean pressure minus right atrial mean pressure. The coronary perfusion in the LCA will be the pulmonary artery mean pressure minus right atrial mean pressure. In fetal life, since the pulmonary artery and aortic mean pressures are same, the coronary perfusion pressures are normal. The situation continues postnatally for about 1 to 4 weeks. The fetal pulmonary vascular resistance remains high, so the pulmonary artery pressures are marginally higher. This continues to maintain the coronary flows. Later, what happens? The pulmonary vascular resistance slowly comes down. So the pulmonary artery pressure falls. Especially during left ventricular systole, the left ventricular cavitary pressure significantly increases above the pulmonary artery systolic pressure. And so this results in flow reversal in the coronaries, resulting in flow of the blood that is flowing in the coronary back into the pulmonary artery, and this leads to significant myocardial ischemia. Moreover, the pulmonary artery's blood saturation is also low, and this results in further ischemia. Extensive collaterals that form as a response of myocardial ischemia sometimes may add to this ischemia. If all these collaterals are going to be on the epicardial surface of the heart, the collaterals from the RCA to LCA may cause a steal of the coronary circulation into the pulmonary artery. We are going to talk now about the classical echo features of Al-Kappa. There are certain features that pertain to the coronary arteries, that is, left coronary artery origin, the markedly dilated right coronary artery, the abnormal excessive flows in the right coronary artery, the abnormal flow reversals in the left coronary artery, the abnormal flows seen in the septal myocardial collaterals. We also will be seeing the features of Al-Kappa on the left ventricle, like left ventricular systolic dysfunction, left ventricle and papillary muscle scarring. We will also be seeing the effect on the mitral valve, which classically presents as mitral regurgitation. This is a short axis view taken from the parasternal window. You can see that the left coronary artery arises from the posterior sinus of the PA. There is also another parallel vessel that is coursing along the left anterior descending coronary artery on the right side of the screen, and this is the great cardiac vein. This great cardiac vein turns around the left AV groove to become the coronary sinus. The still picture of the same parasternal short axis view classically shows the left coronary artery arising from the posterior wall of the pulmonary artery from the pulmonary sinuses. You can see the division of the left coronary artery into a left anterior descending artery and the left circumflex artery. The white arrow points to the LCA origin. In most cases, if you carefully look, there may be a small area of translucency arising almost from the aortic wall itself. We need to carefully differentiate it from a true left coronary artery origin from the aortic root. This lucency is due to the less echogenic transverse sinus of the heart, which is located just posterior to the aortic and pulmonary roots. The way to differentiate that will be to look at the flows in the coronary artery. In Al-Kappa, there is a classic flow reversal of the blood flow from the coronary artery back into the main pulmonary artery. Here we are able to see nicely the coronary flows. You see that the color coding of the left anterior descending coronary artery is blue because the flow is from anterior to posterior. The color coding on the circumflex artery is red because it is from posterior to anterior. And both these vessels merge together and the left coronary artery flows back into the PA with a uniform red color into the pulmonary sinus. I want to once again reiterate the importance of recognizing this second vessel that courses parallel to the left anterior descending coronary artery. This vessel is the great cardiac vein. The LAD and the great cardiac vein both travel in the anterior interventricular groove, while the left anterior descending coronary artery arises from the left coronary artery. The great cardiac vein turns in the left AV groove to continue as the coronary sinus. In some cases, the left coronary artery origin in pulmonary artery can be very close to the aortic root. If this is the situation, translocation of this coronary artery origin back into the aortic root is going to be technically very simple, because the distance between the LCA origin and the aortic root is very small. However, this is not the situation in all the hearts. In some situation, the left coronary artery may even arise well away from the aortic root in the opposite sinus. In this example, you can see the aortic root is seen on the left side of the screen. On the right is the pulmonary artery, and the left coronary artery is almost arising from the opposite coronary sinus. This is another view of the same patient where you can see that the LCA origin is diagonally opposite to the aortic root from the pulmonary sinus. So there is quite a long separation in this particular instance between the LCA origin and the aortic root. This anatomic factor is very important to be documented in echocardiography. When the left coronary artery origin is well away from the aortic root, as in this instance, translocation of the LCA origin back into the aortic root by surgery is going to be very difficult, because you need to mobilize the left coronary artery for a long distance to get it back to the aortic root. The classic color Doppler feature of Al-Kappa is the flow reversal in the left coronary artery. The blood flows from the left coronary artery back into the main pulmonary artery, as seen with in the red color coding on this echocardiography. The best images of Al-Kappa are often obtained after zooming on the coronary origin. Once you go on to the parasternal short axis view, get a small area of the pulmonary sinuses and the aortic sinuses zoomed to a magnified view, and here you will be able to nicely illustrate the left coronary artery origin from the posterior sinus of the pulmonary artery. You can see the clear branching of the LCA into LAD and circumflex. On color flow, we can see a nice flow reversal seen as a red color from the LCA back into the PA. On color Doppler interrogation, the LAD flows in the reverse direction. You can see the blue color coding in the LAD because the flow is from anterior to posterior. You can also see that the adjacent great cardiac vein, which I demonstrated in the previous slides, is also having the same blue color because the flow in the great cardiac vein is also towards the coronary sinus. Another important point to see here is the significant dilatation of the right coronary artery. In this parasternal short axis view fixed frame, you can see the brisk color flows in the right coronary artery as seen by red color. As age advances, the right coronary artery progressively dilates further and further. In this short axis view, you can also visualize the left coronary artery arising from the posterior wall of the pulmonary artery and branching into the LAD and circumflex. The right coronary artery flows become more and more with advancing age due to better collateralization. You can see that the RCA flows are seen even in high velocity scales of almost close to 38 centimeter per second. When we talk about the collateralization from the right coronary artery into the left system, this can be seen in two different views where the interventricular septum is in line with the Doppler angle of the transducer. So it can be seen in parasternal short axis view of the interventricular septum and in subxiphoid short axis view of the interventricular septum. This is a subxiphoid short axis view of the left ventricle. The blood flows in the interventricular septum through septal collaterals from the PDA of the right coronary artery to the septal branches of the LAD. The PDA of the right coronary artery courses in the posterior interventricular groove. The LAD courses in the anterior interventricular groove. And the collaterals that develop between the PDA and the LAD allow the flow of blood from the PDA into the LAD, which means from posterior IV groove to anterior IV groove. So in this subxiphoid short axis view, you can see that the blood flow is from the posterior IV groove into the anterior IV groove through the interventricular septal myocardium. And this is coded blue. The still frame of Al-Kappa shows an uniform blue color coding of the entire interventricular septum. This is due to flow of the blood from the posterior IV groove to anterior IV groove, and this is on subxiphoid short axis view. On the parasternal short axis view of left ventricle, the similar flow from the posterior IV groove to the anterior IV groove from the PDA to LAD takes a red color coding because the flow is from posterior to anterior. In this magnified parasternal short axis view, you can see the myocardial color flow of the septal collaterals taking a red color from the posterior IV groove into the anterior IV groove. This is a classical feature of Al-Kappa. In this parasternal short axis view of the left ventricle, you can see that the blood is flowing in the interventricular septum through the septal collaterals that develop between the PDA of the right coronary artery that courses in the posterior IV groove to the LAD that courses in the anterior IV groove. This is a still frame of parasternal short axis view that shows the red flows of the myocardial septal collaterals from the posterior to anterior IV groove. Another patient with Al-Kappa, here the left ventricle is a little bit smaller, is not markedly dilated. you can see a good collateralization through the septal myocardium. You note the color scales of 61.6 centimeter per second. That means there is a good brisk flow from the PDA to the LAD through the myocardial septal collaterals. If there is a very good collateralization through the septal myocardium, the ischemia to the septum is less, and this preserves the LV function. We need to differentiate between two types of collateralization. What we have been seeing so far is the collaterals that develop from the RCA to the LCA in the interventricular septum at myocardial capillary level. These collaterals will maintain a good myocardial perfusion, and so the left ventricle function will be reasonably preserved. But if there is an extensive collateralization on the epicardial surface with large connections between the right coronary artery and the left coronary artery, this will result in steal of the blood from the RCA into the PA, and this will worsen the LV function further. So a myocardial collateralization is very good, whereas an epicardial collateralization is going to deteriorate the LV function very soon. Next we come to analysis of the left ventricular systolic function. This parasternal short axis view shows significant regional wall motion abnormality. The lateral, inferior and posterior wall are significantly hypokinetic. There's a little bit of sparring of the anteroseptal area. This is because the septal collateralization has been good. However, this sort of regional wall motion abnormalities is not seen in all patients with L-kappa. This is another patient with L-kappa which has almost global left ventricular systolic dysfunction. In some patients where there is an excellent collateralization, the left ventricular function will be very good. In this example, you find that the left ventricle is not dilated, the left ventricular contractility is very good, and there is a good septal collateralization that is seen as a red color through the interventricular septum from the posterior IV groove to the anterior IV groove. We also need to know that in patients who are having very severe mitral regurgitation, the left ventricular systolic contractility may look very good. In this example, with severe mitral regurgitation, the left ventricular systolic contractility is appearing to be good. When there is a severe mitral regurgitation, the low afterload for the left ventricle into the left atrium leads to high values of ejection fraction as we get from Simpson's methods or Ticho's method. When we look at the M mode of the parasternal long axis of the left ventricle, we can find that there is a substantial dilatation of the left ventricle and poor left ventricular contractility. The ejection fraction and the fractional shortening are load-dependent indices of left ventricular function, and so in patients who are having severe mitral regurgitation, the ejection fraction and the shortening fraction may appear high. We also need to identify the scarring of the papillary muscle. If you look at the left ventricle, within the cavity of the left ventricle, you can see the highly echogenic, sparkling white papillary muscles which are thin and fibrosed. Once again, this is another apical four-chamber view showing the scarred papillary muscles within the left ventricular cavity. The scarring of the papillary muscle is a very good clue to the diagnosis. This example also shows the scarring of the papillary muscle. The color Doppler across the mitral valve shows a mild mitral regurgitation. In this example also, the mitral regurgitation is mild and there is a scarring of the papillary muscle, but the left ventricle is dilated and the left ventricular systolic contractility is poor. However, in some patients, the mitral regurgitation can be very severe. This is an example of a severe central MR. There are various mechanisms of mitral regurgitation. As the left ventricle gets dilated, there is an annular dilatation that results in lack of coaptation of the leaflets. In the dilated left ventricle, there may be tethering of the papillary muscles, and this can result in reduced mobility of the leaflets. There can be scarring of the papillary muscle and fibrosis that results in shortening of the papillary muscles. And these papillary muscles fail to contract in end systole, which results in prolapse. If you carefully analyze this video that's running, the posterior mitral leaflets are prolapsing. This is due to scarring of the papillary muscles and failure of the papillary muscle to contract in end systole, resulting in prolapse of the posterior mitral leaflet. When we talk about the various mechanisms of mitral regurgitation, it may be due to mitral annular dilatation, it may be due to tethering of the papillary muscles and the valve leaflets, it may be due to scarring of the papillary muscles and fibrosis of the papillary muscles, it may be due to marked left ventricular dilatation. If you see in this patient, the mitral annulus is not much dilated. The interventricular septal contractility is good, but the lateral wall is very, very hypokinetic. So, the mechanism in this patient is due to tethering of the mitral valve leaflets due to the relatively akinetic lateral wall. When we talk about the surgical correction of Al-Kappa, the most appropriate corrective strategy will be to reattach the LCA origin as a button back into the aortic root. This is called aortic translocation of the LCA. However, in some patients where the LCA origin is located far away from the aortic root, Takeuchi repair may have to be adopted. In grown-up patients or adults, a Lima graft to LAD and ligation of the LCA entry site into the PA is also considered in some cases. This is a picture after the surgical re-implantation of the LCA back into the aortic root. You can see that the long LCA getting its origin from the aortic root. This is another example of a re-implanted LCA. Even the coronary flows in the LCA after re-implantation can be nicely documented by putting the pulse wave Doppler cursor across the proximal LAD. In the spectral Doppler pattern that has been shown in this picture, you can see that there is a diastolic flow. The two arrows mark the beginning of diastole and end of diastole, and you can see a good diastolic flow in the re-implanted coronary artery. If aortic translocation of the LCA is the ideal method, then why can't we adopt this technique in all the patients? Why should we talk about Takeuchi repair as another modality of treatment? This is an example of an Al-Kappa. The LCA arises from the left wall of the MPA exactly opposite to the aortic root. If this LCA has to be translocated to the aortic root, the left coronary artery origin has to be mobilized for a very long distance up to the aortic root. In these cases, it may be appropriate to go for a Takeuchi repair. This is the two-dimensional echo of the same patient. You can see the left circumflex and the left anterior joining together form the LCA, and the LCA is getting attached to the wall of the pulmonary artery, which is diagonally opposite to the aortic root. So this LCA origin is quite far off from the aortic root. After an extensive discussion of Al-Kappa, in this slide we will show a few examples of anomalous right coronary artery origin from the pulmonary artery. This is a very uncommon anomaly. Unlike Alcapa, this does not produce a severe ischemia, and so the clinical presentation may be missed. Some patients may have mild LV dysfunction. This is a parasternal short axis view of a patient with anomalous right coronary artery from the pulmonary artery. We are concentrating on the LAD flows. You see, the LAD flows are having a mosaic pattern, which means the velocities are more than 62 centimeters per second. Accelerated flows in the LAD. The accelerated flows in the LCA and LAD is well appreciated in this parasternal short axis view. We were talking about the septal collateralization in Alcapa. In anomalous right coronary artery origin from the pulmonary artery, the septal collateralization will be in the reverse direction. That means the blood flows from the septal branches of left anterior descending coronary artery to the posterior descending coronary artery branch of the right coronary artery. And so on a parasternal short axis view, this is going to show as a blue color coding of the septal collaterals in the interventricular septum. In most of the patients, left ventricular systolic contractility is rather well preserved. You can see that in this patient there is only a mild left ventricular systolic dysfunction. This is a transesophageal view of the same patient. Because of the adult survival, a transesophageal echo is possible. You can see a brisk flow in the left coronary artery and a brisk flow in the left anterior descending coronary artery, which is arising from the LCA. There is no right coronary artery origin that is seen in the right coronary sinus. When we measure the left coronary artery ostium, it is so dilated, it's almost around 8 millimeters. When we analyze the Doppler, spectral Doppler flows of the LAD are showing an accelerated flow. See that there is a diastolic brisk flow in the LAD, and the velocities in the LAD are almost touching 2.5 meter per second. So there is a high velocity brisk flow in LCA because the LCA collateralizes the RCA territory.